Good evening, everybody. Now, this is very challenging session in a sense that I've been given a task to keep you people awake after such a nice and hearty meal. I'll try my best actually to do that. In this session, we have selected three of the interesting cases from wide spectrum of rheumatology. Main purpose to select those cases were these cases represents pieces in the spectrum of rheumatology mixed with non-rheumatological manifestations. Basically, they were selected for that. First case. This is a case of a middle-aged gentle female. She was 52-year-old age. 52-year-old, actually females don't like themselves to be called elderly, so I'm using the term middle-aged. She presented to us a couple of months back. Her main complaint at the time of presentation was, along with polyarthritis, she had but main chief complaint was pain in both the knees and left hip since 2 years, which was more troublesome for that lady, and this was worse since last 2 months. This pain was pretty inflammatory in nature, suggested by presence of morning stiffness, which was more than 2 hours. Along with that, other troublesome features were headaches, which lady had since last couple of days, last 2-3 months, which on history looked like episodes of migraine. Dyspnea also she had, which was grade 2 dyspnea, but that was not that troublesome at that point of time to her. Then on examination, there was a restriction, that is flexion deformities in the knee joints, plus severe restriction at the left side of the hip. It was very painful movements. Now there is one very interesting history attached to this case. This history of this female started right in 1978, when she had polyarthritis along with pain in both the hips, and she was diagnosed as avascular necrosis of right and left both the hips in 1978. But at that time her left hip replacement was done. Right hip was not attended surgically due to unknown causes, because details of that surgery was not available. She worked, her hip worked fine. She had on and off attacks of polyarthritis since up till 1996. When she had fracture in her left humerus following a trivial injury, just bump on a wall or a door, something like that. She had a fracture of the humerus, which again took 6 months for total cure. She had off and on polyarthalgia, which increased according to the patient in 2002. With other investigations which were done, she was also checked for rheumatoid factor, which came out to be strongly positive. And with this finding of rheumatoid factor positive and inflammatory markers being high, she was started on treatment with DMARDs like methotrexate and hydroxychloroquine, which she took non-stop regularly. Then in same year, 2 years later, she had pain in the calf and left ankle, for which she went to a doctor who suspected some clot in the lower limb, for which she underwent a Doppler study. I don't know, like details were not available, but maybe that time our dear radiologist was not that sure about the finding. He just commented query DVT with some amount of absence of flow in the popliteal vein. So for that, the patient was started on anticoagulants, which he took for the short period. Finally, her hip gave way in 2005, which was again reconstruction was done in the same year. Then same year, patient developed pain in the right ankle. According to the patient, she developed some rashes over the ankle and shin of the right leg, which took around 2 to 3 months to heal. But documented evidence is not there that it's the vasculitic rashes, but we presume to be it as a vasculitic rashes because it was a coin-shaped lesion and which took very long to heal. Then X-ray, along with other investigations for connective tissue disorders, her ANA came out to be negative at that time. X-ray was done of the ankles and of the knees, which showed severe osteoporosis, and lower limb Doppler studies was totally negative. When she presented to us, we reassessed her disease status. We found that her inflammatory markers still were very high and rheumatoid factor was still very much positive. These are the few pictures which indicated, which shows the X-ray of the ankle and knee which was done at that time. As you can see, there are some lesions which look like moth-eaten, which gives moth-eaten appearance to the distal femur and proximal tibia, and there is generalized osteopenia both in the X-ray of ankle and X-ray of the knee joint, with some amount of joint effusion and meniscal tear were also found. These were the finding present in both the knees. And the other icing over the cake was the patient was having on and off polyarthritis since 2002, but she also had history of frequent blood transfusions. Couple of times she developed anemia. For that she was given blood transfusion. During 2 surgeries which she had, which increased her joint pains, she required blood transfusion. And interestingly, her blood levels, hemoglobin levels, never fell to an alarming low level. That is around lowest documented hemoglobin level we found was around 6.5 and 7. The hemoglobin always remained in the range of 6.5 to 9, like that. Now, with the history, this historical evidence and present history, can anybody guess the diagnosis?
Yes, sir.
Pardon? Okay.
Any other thought process?
Secondary APS.
Okay.
Secondary APS.
Possibly. What prompted you from thinking of secondary Apoorva syndrome here? So this patient has got symptoms since 1970s. With the hip started with probably around that time hip replacement, and subsequently many episodes of so-called self-limiting arthritic episodes, and presenting in the last 1 year, 1 or 2 years with persistent knee pain and hip restriction of movement. Do you still consider rheumatoid arthritis in this patient? Historically, from what Apoorva has said, the patient has never had a small joint involvement. Rheumatoid by definition involves small joints, and it is a persistent arthritis most of the time, unless the onset could be palindromic. First few years it can run like intermittent arthritis affecting few joints here and there, self-limiting episodes, but over years it becomes more persistent. So would you still entertain rheumatoid arthritis as a possibility here? Any other comments?
Sir, rheumatoid arthritis with the secondary anti-phospholipid antibody syndrome.
Maybe the repeated blood transfusion may be due to methotrexate-induced bone marrow suppression. If the possibility.
And
Methotrexate-induced bone marrow suppression because he undergone repeated blood transfusion. When the avascular necrosis may be due to whether the patient is on steroid or not, it is not given in the history. It may be due to steroid-induced avascular necrosis, or it may be due to rheumatoid arthritis itself because it increases
Steroid was used for a very short period of time.
oxygenated
Just burst
atherosclerosis.
of steroids. Steroid was never regularly used. Only methotrexate and hydroxychloroquine.
Or rheumatoid arthritis itself, it stimulated the atherosclerosis, accidental atherosclerosis. It can cause secondarily avascular necrosis.
but this illness started almost with an avian. We will put it that way. I mean, whatever we know from what he has told, the illness started with an avian. Almost the beginning itself. Avian is an early event here, not a late event.
Probably we can consider hyperparathyroidism because of the cystic nature of the bony unit.
Yeah, that's a good thinking, but I think the duration of illness of more than 15-20 years, probably little longer for hyperparathyroidism to go undetected.
No,
And,
no bone pains or something like proximal muscle weakness.
I think there are basically, if you want to link up all the
Probably-
things into, yeah, please.
Sickle cell trait with transfusion-induced hepatitis is possible.
So if you,
Right,
there are two ways. One is to have all the things being explained by one disease, which we normally try to do, rather than have two different things. For example, if you think of hyperpara, one still would have to explain the AVN with something else. So there are two ways of looking at it. I think one is to have one diagnosis explaining all the things, which we always try to do, and for that I think one would think in terms of a coagulopathy and a congenital hemolytic kind of what they have just referred to. The other is you have AVN as a different thing, and you think of these metabolic disorders like. So these are two processes by which you could actually think. About bone marrow suppression and methotrexate, it's not so common with methotrexate, and you have a rise in MCV before you see a drop in hemoglobin with the use of methotrexate. It is not very common. Bone marrow suppression methotrexate is only when you have those kind of genes, those bad kind of genes where you are very vulnerable to methotrexate, and that is very uncommon in our population. So and methotrexate was not used for a very long time to suggest repeated blood transfusions for so long, So I think that doesn't explain the anemia part, and anything else that.
She is a 52 relative who has survived fairly long and has got history of multiple transfusions since many years, since almost last 20 years, and has got episodes of bone pain, and significant history is avascular necrosis and a low trauma fracture. Gouchers.
AVN idiopathic gouchers is one thing that does lead to, but again,
Goucher is not an episodic type of, the nature of pain in Goucher. Goucher is a very rare disease. I have not seen one, so I can't really comment from experience, but it is a kind of avascular necrosis is common, but is never an episodic, and the significant anemia cannot be explained. Lupus is an interesting thought, but the duration of illness last 20 years going on without developing a major organ involvement is pretty unusual.
the ANA being negative.
ANA is negative.
Hereditary spherocytosis.
Hereditary.
No, you are right in thinking of some hemolytic process. I think the senior most doctor has given us the diagnosis. Go to the next slide. Next. I think we'll give away the diagnosis. It is sickle cell disease. I think big hands to the doctor there.
Actually, I wanted to ask, should we consider here the diagnosis of rheumatoid arthritis also? Because rheumatoid factor positive since 2002, significant inflammatory joint pains, history of taking DMARD. Should we consider rheumatoid arthritis in this scenario or not?
Dr. Apoorva, have we checked hepatitis C status, liver function?
It was checked outside, sir. It's negative.
Because of multiple blood transfusions, Hep C infection could cause a persistent rheumatoid factor positivity even in the absence of rheumatoid arthritis. So we should always, this probably rheumatoid factor was a false positive rheumatoid factor in this patient. Coombs was negative, I think.
Coombs was negative.
So it is a very classical, though this patient has done extremely well to survive without a major problem until 1952. But there are few things like avascular necrosis is very, very common in sickle cell disease, and the revision, even the survival of a hip transplant is also very small or a very for a low duration in the sickle cell disease because of the bone destruction. So this patient required a revision within 7-8 years. So that is also an important thing, and the patient has become osteoporotic and had a very low trauma fracture. So I think sickle cell diagnosis should be suspected in this kind of patient. This patient had episodic severe bone pain. In some odd situations, people have investigated, found to have high rheumatoid factor and treated the test rather than the patient. This is what has happened. Pardon?
Splenomegaly.
There's no splenomegaly clinic.
Heart was splenectomy.
This patient actually shows the X-rays. The X-rays shows kind of lytic lesions and also some bone infarct. These are the white areas are probably old healed scars of earlier bone infarcts, bone ischemia. So during each crisis, even the ulcer, skin ulcer could be explained by sickle cell disease. Because in this part of country, we don't see sickle cell anemia that commonly. So unless you have a high index of suspicion, the chance of us picking it up in the first instance would be low. We'll start thinking of so many other things. Anything else?
Sir, here I have a question. Like in malaria endemic area like India, is that the sickle cell is a rare entity or it's like relatively common entity?
It is supposed to be common in certain part of India, and I think some part of Kerala and some area of Rajasthan and Gujarat, they report more cases.
Here also in Bilagiri Hills, sickle cell anemia is seen in tribal people.
Tribal people.
In tribal people at Bilagiri Hills in Karnataka state.
Chindis. So this is an general medical patient presenting to a rheumatologist with a possible rheumatological diagnosis. So that's the reason most of the rheumatologists should remain a good internist. Longer we lose touch with internal medicine, we rheumatologists, we ourselves might miss this kind of patients because our thinking process is more tuned to autoimmune diseases. We would sometimes miss a general medical illness which presents with musculoskeletal manifestation. But if you look at sickle cell disease, musculoskeletal manifestation is a dominant symptom in these patients because we don't see them that often. We don't think about it that frequently. Go ahead.
The second case of the day is a very intellectual gentleman of 49-year-old. He was pretty young by heart at this age also. He presented to our casualty with tense and tender swelling of left knee, which according to the patient was sudden in onset. It came within a period of 2.5 to 3 hours to its full extent. It was in left knee, and again according to the patient, it was pretty inflammatory in nature with significant morning stiffness which lasted for more than 1 hour, and there was a significant limitations of the movement at that particular joint. Other joints were totally pain free and there was no signs of inflammation. So in a nutshell, it was a monoarthritis. Now, historically, patient gave a history of 2 to 3 episodes of same sort of swelling in the same joint over the last 3 months period. And interestingly, it subsided with use of NSAIDs. Swelling was not that much up to the present extent, but some amount of swelling which lasted for few hours, and it subsided with the use of NSAIDs.
Yeah, I'll stop you here. What are the possibilities? Any thought process here? He's a middle-aged man with recurrent episodes of monoarthritis.
It's hemophilia, sir. Hemophilia.
Hemophilia in an adult male is little unusual. The onset of symptom is only few months. It's a good thought process.
Sir, why is possibility of simple osteoarthritis, which comes and takes medicine with analgesics, the pain subsides and again he comes back with the pain. Simple case of osteoarthritis.
Osteoarthritis with an acute effusion. Probably some amount of crystal shedding happens in osteoarthritis, which can cause a recurrent effusions. I agree with you.
And another possibility is a gouty arthritis involving the knee joint, though it is a little unusual, still possible.
Fantastic. So in acute monoarthritis, the differential diagnosis is only 3. Either it has to be trauma, hemarthrosis, as told by the doctor, hemophilia, and crystal arthritis. Either it could be gout or pseudo-gout. Pseudo-gout is a little more common in knee joints, particularly those who have osteoarthritis. People who have certain metabolic syndromes are more prone to develop pseudo-gout in the knees. So if you look at carefully the X-ray, sometimes you see a faint calcification in the cartilage. The third possibility, if it is not recurrent, acute monoarthritis, is septic arthritis. In this case, sepsis is ruled out because it is recurrent and self-limiting. So the possibility left with are either there is no history of trauma. There is no history of major trauma. So a traumatic arthritis is less common. So crystal is a dominant clinical suspicion at this stage. Because it happened in the knee, we did suspect a pseudo-gout rather than a gout, but gout is definitely a possibility. Go ahead.
Spondyloarthritis.
Seronegative.
Early morning stiffness is there. That shows it's not limited to the joint. Early morning stiffness, limitation of movements.
No.
At the particular joint.
Any joint which is swollen.
So say ankylosing spondylitis, an atypical presentation.
This patient doesn't have the information available to us is single joint swelling, recurrent, self-limiting. This presentation is little unusual in seronegative spondyloarthritis. They can get recurrent episodes over many years. They will have one episode of knee arthritis and few joint involvement. Patient historically they might give we have a similar illness few years back, 4 years back, 5 years back. It's not in the duration, the episode within 2-3 months self-limiting episodes. I will not think of a seronegative spondyloarthritis in this situation. Anything which swells up the joint will cause stiffness, early morning stiffness and restriction of movement. So that is not an indication to consider the inflammatory arthritis at this point of time. Let the more information come.
Sir, at this point, I'd like to ask why there was such a good response with NSAIDs only, without any therapy, like any medication?
Any simple inflammation.
After diagnosis, it will be very easy.
Any simple inflammation into the joint, like osteoarthritis, pseudo-gout, responds very well to NSAID. Even gout, the drug of first choice, is still NSAIDs. So, good response to NSAID, chances that there is an inflammatory component, probably.
There are two things. One is that spondyloarthritis or seronegative spondyloarthropathy at this age is slightly, the age is more. You would think of a spondyloarthritis at a young age, a young male patient, although it can be seen in elderly, but as he said, it is not in 2-3 days it subsides and then comes back. It's more often 2 years back, lasted for 3 months kind of thing. The other thing is response to NSAIDs is taken as a criterion reactive arthritis, although not again in this setting because we are not saying that. But here it is probably what the one that said, that is just inflammation which is responded to. It could be gouty or CPPD or anything.
The second slide is little more interesting. On examination, there was a tense effusion in the left knee joint, tense to the extent that it was firm to hard in consistency. Historically, there was no history of trauma or tuberculosis or any family history or present history of gout or any bleeding disorders in the family. 2 to 3 months he went to a lot of 2 or 3 doctors he changed, who put them on steroids, some suspected gout, put on zycolchicin, but with no relief. Here we had a little interesting, I had little interesting confrontation with Dr. Dharmanand. As soon as the patient came to the casualty, I aspirated the knee joint. It was a frank blood actually. So I told to Dr. Dharmanand that I got frank blood from the knee joint. So like he was pretty upset with me that thinking that I might have ruptured some vessel or something. So he said, no, I'll try that. So he tried, again he got the same result as a frank blood only. So finally we signed the fluid for analysis. Bleeding time, clotting time was normal with normal INR. There was no crystals found. Total count showed only RBCs, otherwise no other cells. AFB was sent, which came to be negative, and rheumatoid factor was also negative.
So shall we open the discussion now? Now we aspirated frank blood. So some of you suspected hemophilia, like it's a hemarthrosis. I'll put it that way. We can't call it as hemophilia at this point of time. It's a hemarthrosis, and which has occurred in the absence of trauma. So what are the possibilities here?
Whether blood clot, fat globules?
It was frank blood.
Frank blood?
No fat globules.
Okay, it may be hemarthrosis, or it may be a synovial sarcoma, or it may be a pilonodular synovitis.
Very good differential diagnosis.
The synovial hemangioma.
Very good. Again, one more very good differential diagnosis. Would somebody suspect still an osteoarthritis? Pseudo gout is known to have sometimes hemorrhagic effusions. So outside it is possible, but this gentleman had a very, very frank blood. So we have to start thinking of, he has bled into the joint, and the synovial fluid did not clot. That would mean that the fluid, the blood was there in the joint for a long time. It is not a fresh bleed because of Apoorva's adventure. So when we aspirate clear fluid and then it turns bloody, then it is always due to a synovial. We might have touched a sensitive area in the synovium and bleeding might have happened. If the bleeding has happened after that, generally it forms a clot. If synovial fluid and if there is a traumatic blood, you generally end up the synovial fluid, if you collect it, you find clots. If it doesn't clot, then it is a hemarthrosis. So it is a case of hemarthrosis. Come next. But the differential diagnosis told by you are fantastic.
Sir, can we consider as a popliteal artery aneurysm as a differential diagnosis? Though it's rare.
No, aneurysm is absolutely posterior. You can't.
There is one case report from Germany, sir. Actually, they said there was a recurrent same sort of history in a 54-year-old male. All the causes were ruled out. Later on, they found that there was an aneurysm of genicular artery. So it used to bleed in the joint again and again. So it was causing recurrent hemorrhage.
That's a branch of popliteal artery. That's not popliteal.
Yeah, branch of popliteal.
Branch of superior genicular artery.
These are some of the radiological pictures from those patients. Knee joint, as you can see, there is a minimal hyperdensity over the cartilages in X-ray wise, and MRI wise, you can see the effusion. That arrow is marked over there. Effusion with villi which is folded up, indicating that there is a synovial hypertrophy. Along with left side, you can see some bucket handle tear of the menisci, lateral menisci. Now histopathologically, there was a fibrocartilaginous tissue lined by hyperplastic synovium thrown in form of villus. Stroma showed macrophages along with lymphocytes. This is the histopathological picture of the patient. Any conclusive diagnosis?
PVNS.
Pardon?
PVNS, pigmented villonodulosynovitis.
That is the diagnosis.
Yeah.
That's a diagnosis.
Histopathology.
And even the MRI did show evidence of hemosiderin deposition in the synovium, and the histopathology was not kind of textbook like, but it did show a prominent villus formation and presence of hemosiderin in the synovium, and lot of macrophages were there. That was the out point actually. The diagnosis probably is pigmented villonodular synovitis. And how would we go about treating?
Actually, the patient refused the treatment, definitive treatment for that. He refused the orthopedic intervention.
No. The options are synovectomy, isn't it? And open or radiosynovectomy.
He is happy with what he has.
Pardon?
He is happy with what he has. He don't want to get.
At this moment, I think anybody would be scared of open surgery to the knee, being a medical professional, I should say. But synovectomy is the treatment, and the choice between arthroscopic synovectomy, open synovectomy, and radiosynovectomy is very difficult to make. And all three options were given to him. So the patient is still trying to choose. So this is where we are.
The last case, actually this is the, what according to me it's the most interesting case of the lot, presented to the OPD of Dr. Dharmanand. Main complaint was tense right knee effusion, which he told, which was there since 4 days. Then he was having purulent discharge from both the ears. That was, according to the patient, was also from 4 days. And as accompanying this, there was a high-grade fever with chills and rigor. That was also from 4 days. Now this child also had little history attached to him. In 2008, child had arthrotomy with lavage of the same knee, left knee for septic arthritis. This time the presentation was right knee. The arthrotomy was done of the left knee with lavage in 2008. And at that time, some investigations which were done was blood and synovial culture and sensitivity didn't yield any result. AFB gram stain was negative, ANA was negative, hemoglobin was on lower side, which was around 6.8. Total count was showing inflammatory picture. LFT and creatinine both were normal. Then coming to the next complaint, which was discharge from both the ears. This complaint was on and off since 2 years, but recently he was diagnosed as bilateral CSOM of both the ears.
Can we stop here?
Yes.
So this child, there is a history of recurrent episodes of some possibly bacterial infection-like activity in the ear and in the joint and the septic arthritis, and there are recurrent episodes and high fever. So there is, and plus the anemic picture is there. So there is a strong possibility of immunoglobulinemia causing making the child prone for recurrent infections. Recurrent infections anywhere in the body, including septic arthritis. That's a possibility.
Very good thought process. This child has presented to us like what looks like a acutely hot, tender joint. Like as I told you, monoarthritis, sepsis, crystal trauma. No trauma in this child. There is no 5-year-old child. We don't suspect crystals. So the most likely diagnosis we had is septic arthritis or a very acute presentation of an autoimmune arthritis. In the background of CSOM, a septic arthritis is a very likely diagnosis. And historically the child has had a previous episode on the other knee which also sounded like a septic arthritis and treated like septic arthritis by the pediatrician and the orthopedic surgeon in his native place, Merkara. So this is where we stand. Go ahead.
Few days back, he had severe sinus infection, pleural sinusitis, pansinusitis. For the first time, his pus yielded some organism which was Staphylococcus aureus. Then child history dates back when child was 4 months old, when he had his first episode of mnemonic consolidation. According to his mother, it was this LRTIs and URTIs were very common occurrings, with average 1 to 2 episodes of severe LRTI and URTI, which required hospital administration with administration of IV antibiotics around maybe 200 days per year.
So, what do you think now? This child has got recurrent infections since childhood. Go to the previous child slide. What do we infer from this slide?
Some immunodeficiency syndromes.
Yes, and
Another possibility is HIV also to be kept in mind, because recurrent infections in different parts of the body, possibility of HIV.
yeah, of course, that is also an immunodeficiency syndrome.
Immunoglobulin A deficiency,
Why? How?
recurrent infection, consolidation, more chance of infection.
Isolated immunoglobulin A, IgA deficiency. Okay. Pardon?
Histiocytosis X. Sinus histiocytosis. Well, whenever you're thinking of a congenital immunodeficiency syndrome, which has been rightly thought of, although I'm not dealing with immunodeficiency as a rheumatologist, but since we learned immunology, you start thinking in terms of whether you're thinking of a humoral deficiency, whether you're thinking of a cellular deficiency, a T cell arm, or the humoral deficiencies, antibody arm, or complement deficiencies. The humoral deficiencies would present more often as bacterial infections, as sinus problems, recurrent pneumonias, bacterial infections because of the antibodies or the immunoglobulins being deficient. Whereas the T cell arm deficiency would present with oral candida and intracellular pathogens, I think mostly like Listeria monocytogenes or those kind of. There are some other organisms also. So T cell arm deficiency, a B cell arm deficiency, or a combined deficiency. A severe combined immunodeficiency is the most pathetic form where children don't survive for very long. So these are the things you start thinking as the patient presents. And complement deficiencies would, of course, sometimes have your NA positivity and lupus, but basically immune complex deficiency would be there. So these are the things that you think of when you're thinking of immunodeficiency and asking those questions. Another question to ask, which we were taught, I think then, was to see the response of the child to vaccines. Normal children get a response to vaccine in terms of fever, and these children will not get a response to vaccines. Vaccines, after getting vaccines, they will have no kind of fever or those kind of things that they have. So these are the things that you look for in these, and of course a family history of a similar death in a sibling, especially we have had those cases whose brothers had died and kind of thing, young age. So these are the things that one asks these patients, these children, basically.
Yes, I mean that's.
Sir, a small question to you. You just said we consider it as a congenital immunoglobulin deficiency. But if we take this in account, then why this presentation was not from birth? It started around 5 to 6 months back, like when child was 5 to 6 months old. Until then, child was fine.
They started quite early, 5
That is the point.
So possibly it is presented late, but 5 months or 6 months of age is not really late presentation. It is, you can call it early presentation only. And another strong thing is the mother breast milk has got a lot of immunoglobulins, which gives protection initial few months.
Even the other way looking at it is the immunoglobulin transmitted through placenta, IgG, stays for at least 3 months before start coming down. So that is a crucial period where children are generally vulnerable for infections between 3 to 6 months, where mother's immunoglobulin has started coming down and the child's immunoglobulin has not picked up. That's a transition period. This is a good pointer that the child started first major pneumonia at 4th month, 5th month would lead us somewhere towards probably whether the child has got an immunoglobulin deficiency. And any child which has got more than 2 episodes of pneumonias, more than 2 episodes of major sinusitis or CSOM requiring antibiotic or hospitalization, we should start thinking of an immunodeficiency syndrome. Here we presented because this child has been going around for the last 3 years to pediatricians and various doctors. Nobody has suspected an immunodeficiency syndrome. In a normal case, even if the child has got 2-3 major hospitalizations per year with infections, we should start thinking of immunodeficiency. Then if you start thinking, 1 in 10 will turn out to have, are probably an immunodeficiency syndrome. Majority of them, the infections could be due to any other cause, like a local cause, and depending upon the socio-economic status. So many school-going children infections are very common. But still, we should start suspecting when there is a major infections. Go ahead.
This is the few pictures which we took during the aspiration of the knee joint. We gave the saline lavage, but by the time I could click the picture of steroid instillation, which Dharmanu sir was very quick to do that. The procedure was over, and child was very happy after that. Now the immunological parameters, all the antibodies were low. CD3, CD4, all the counts were done. Out of that, you can see that CD20 count is this very low. That is just 0.37 of the total count. Can anybody tell me why this CD20 count is so low? It was 0.37. So diagnosis is just primary immunoglobulin deficiency. The most common variable is common variable immunodeficiency. And treatment which we offered actually is a lifelong treatment. Immunoglobulin infusions should be given based upon the response of the patient. The dose of around 400 mg per kg body weight as a IV infusion, lifelong. Actually, it depends upon the individual response. Generally, it's recommended 1 to 1.5 months to 2 months once. But some patient, it has a dip in the levels much early. So we have to give. In some patients, like extreme of the cases, you have to go even up to weekly or daily infusions. That depends upon the patients. Cost is very high actually. 7,000. 17,000 per, 15.
Apoorva, go back to the previous slides.
What is the role of sulfur?
Actually, the patient since few days he was developing features suggestive of IBD, inflammatory bowel disease. With
I'll tell about that. See, go back to the couple of the previous one. Come. Next. Okay, these are the few things. You can read this slide to them. You can read this slide.
Yeah.
This is an important history. Only pediatricians would know. For non-pediatricians, this is one important bit of history to take when you are suspecting immunodeficiencies.
Skin infections and fungal infections are more common in T cell deficient arm, which was not found in this case. Before 4 months of age, there was no history of any infection. No history of delayed separation of umbilical cord stump, which is again a function of macrophages and neutrophils. BCG vaccination scarring was also okay without any big abscess formation or any other reaction to any other live vaccines. And this child didn't have any other family history of same complaint. Though he developed IBD symptoms in form of gastric upsets and few episodes of loose motions with crampy abdominal pain, so we thought of, as told by a doctor, a component of inflammatory bowel disease which may respond to sulfasalazine. So keeping that in mind, we started sulfasalazine, and after 2 infusions of immunoglobulins, which were very frequent, very close by, child is somehow maintaining. Since 1 month, he has not had any infection. So maybe it's due to sulfasalazine, or maybe it's immunoglobulin not dipping or recurrent infection. But this is the truth.
I will try to summarize what we did. This child came to us with right knee, what looked like septic arthritis, unfortunately, we could never grow an organism. The first aspirate showed about 20,000 cells and cloudy fluid, as you could see from the picture. We could never demonstrate an organism. We tried to inoculate into a culture medium directly, and the gram stain was negative. And the child did extremely well with IV antibiotics, and the patient has received 4 days of ceftriaxone before the child came to us. So we assumed that we could not grow organism because of previous exposure to antibiotics, and we treated him like septic arthritis with which covers gram-positive organisms because of CSOM, which isolated Staphylococcus. And with 10th to 14th day, the child, and we also gave him 400 milligram per kg immunoglobulin. With our clinical differential diagnosis was whether it is X-linked agammaglobulinemia like Bruton's hypogammaglobulinemia or combined variable immunodeficiency. We thought his B cell count is reasonably all right from the CD20 count, and we thought that they didn't have any T cell defect because CD8 count, CD4 counts were normal, and he tolerated the viral vaccine, live vaccines very well. Somebody who has got severe T cell deficiency would not have tolerated live vaccines well, and he did show a BCG scar in his hand. So we assumed that his T cell arm is reasonably fine. And 15th day, his right knee swelling recurred while with antibiotic, and fever also started coming. We did the immunoglobulin levels. Again, it has gone back to very low levels. Again, we have to give him one more dose of IV immunoglobulin at the same dosage. During infective episodes, they consume immunoglobulin a little faster also. So we may require it every 15 days, but long-term maintenance is supposed to be every month. Then once they become very stable, we can stretch it a little bit depending upon how the patient does. I also boldly injected his joint with a little bit of steroid because there is a possibility that this could be an aseptic or pseudoseptic arthritis which is known to occur with some of these patients. Autoimmune phenomena like inflammatory bowel syndrome and aseptic arthritis, juvenile rheumatoid-like arthritis are not uncommon in primary immunodeficiency syndromes. And even animal experiment wise, septic arthritis treated along with adequate antibiotics, little bit of steroid has got less deformity, because during a septic arthritis, the amount of cytokines, amount of matrix metalloproteinases produced in the joint is enormous. Within 5 to 6 days, knee can get permanently damaged, and he already has got a flexion deformity in his left knee. So we took a gamble and gave him a little bit of steroid, continuing the IV antibiotics for the next 14 days. I've just switched him over to oral antibiotics, and because we still have a differential diagnosis, whether it is a mild form of agammaglobulinemia or CVID, we have sent him to PGI Chandigarh, where there is a pediatric immunology department where they have facility to do the gene testing. So at this moment, the diagnosis is sulfasalazine is added with that in mind. He had little bit of loose stools which could be antibiotic related. We don't know, but I have given it more for a possible aseptic arthritis. We couldn't give methotrexate. We couldn't give any other immunosuppressive disease modifying drug. So we gave him sulfasalazine very empirically and treated him with local steroid. We don't know which worked. His knee joint is absolutely fine 25 days after the second aspiration, and we have just sent him to PGI Chandigarh for kind of second opinion. This is where we stand.
Sir, regarding the intra-articular steroid injection in a child with septic arthritis, it looks a little controversial.
It looks scary to everybody.
Scary because it is a steroid injection to the joint it is like a contraindication whenever there is an infection.
That is a popular perception, but there is a good evidence to say that a little bit of steroid injection during an acute septic arthritis does more good than bad. Because septic arthritis is very, very inflammatory arthritis. Very, very inflammatory arthritis. If you you have to do daily aspiration and you have to lavage, and still people end up with a permanent damage. And there is a good evidence even from some of the clinical studies and also animal experiment that steroid injected joint do well. Right? I have injected at least 6 or 7 septic joints without any complication. All the injected joint were doing still well. the non-injected septic joints which has happened in a dermatomyositis patient earlier, they have a flexion deformity.
How exactly do a complete aspiration of the pus and
Complete
some
aspiration,
saline wash and then steroid?
saline wash, and give a small dose. Small child, I gave only 10 milligram and pushed it. Pardon?
Septic arthrotomy, you mean open the joint and
No.
do lavage?
There are two options, whether you can do a open arthrotomy, arthroscopic lavage, or a closed lavage. If you look at the clinical studies, all three have done very similarly. It is less traumatic. So repeated aspiration is supposed to be as good as if you could do, unless there is a loculated fluid, it's as good. And this child, there is always a doubt because we never grew organism. It could be a pseudo septic arthritis, which is a sterile possibility. So the steroid might have worked for that also, because this is a difficult area. It looked like a septic arthritis, behaved like a septic arthritis, aspirate looked like septic arthritis. The cell counts were little low. I am not sure whether it is due to some amount of immunodeficiency also, whether that itself has reduced the neutrophil infiltrate, though there is no obvious neutrophil defect in these syndromes. Whether that has attracted less neutrophil to the joint, or whether it is a pseudoseptic arthritis from the beginning, we don't know.
So it's a standard teaching in orthopedics to say that you never allow a sunrise or sunset in an infected joint. It's an emergency, just go ahead and do arthrotomy and give a proper wash, whatever it is. But you just do aspirations, and are you happy with that, sir?
Yeah. Even if you look at European Rheumatoid Association or British Society of Rheumatology septic arthritis guidelines, even in adults, close lavage is an accepted. If there is a loculated effusion at close lavage, every day you aspirate, still lot of thing accumulates. Then you have to go for an arthroscopic or open lavage.
Thanks, sir. Very good information.
Sir, I am not talking about this case. Lot of diabetics come with the osteoarthritis. How common is septic arthritis after steroid injection into the joints of diabetics?
No, I don't think, diabetics, if you inject intra-articular, I have not had problems with septic arthritis. Not that I inject so many, but I don't think there is a problem that much. And intra-articular steroids does not lead to that much of increase in diabetes. That is also something that has been reported. But I haven't patients of mine have not reported to me, and in literature, I'm not aware of any increased, I think they are as good.
Intra-articular injections in diabetics have been safely done, and the only problem is we would ensure that the diabetes is under fairly good control when we, at the time of injection, though there is no proof what will happen if I inject a joint with the blood sugar 400, but that steroid injection itself could bring it to 500 and they may end up with the ketoacidosis. So we ensure that the diabetes is under good control. We ensure that there is no infection at that point of time. See, most common cause of septic arthritis, even after an intra-articular injection, is hematogenous spread. Rather than introducing, if you take proper precautions with the good sterile precautions and no touch technique with a glove or without glove, the chances of introducing a bacteria into the joint is very low, because it's a fine tip of needle. Even if it takes inoculum of bacteria into it, the amount is supposed to be so small to cause it never gets a foothold there. And also the xylocaine which we use to dilute the steroid also has got an antiseptic effect. So all these things protect the joint against septic arthritis. But if the patient has got a fever or an ongoing septicemia, that patient's better to avoid. Somebody who is having a severe cough, respiratory infection, infected skin ulcers, I won't inject, because by giving a steroid injection, we injure the synovium. That could be a nidus for a bacteria to go and sit there and start an initiating process. In my last 12 years experience, only one patient has got a septic arthritis. The patient had the diarrhea. I had ignored it and given it a septic arthritis because the knee was so tense. So that aspirate was never infected. But the patient grew E. coli or something which was identified from the blood as well. So it was hematogenic spread. We never had a direct inoculum septic arthritis so far, touch wood. But the incidence is 1 in 1 lakh. Infections can get septic arthritis.
So just 3 or 4 points in that case. One is that celiac disease sometimes does present in this way. Celiac disease in children, failure to thrive, and associations of GRA are known. The other is complement. You can have ANA positivity, as he said, autoinflammatory. You can have ANA false positivity in immunodeficiency syndromes. The third point was that most of these diagnoses require sophisticated tests, as he said, and they are genetic tests which are required for a correct, exact diagnosis. Sometimes we used a MON2 test to check the delayed type hypersensitivity arm. These patients have a negative MON2, which suggests energy, which could tell that the DTH arm is defective. And the last, that the final cure of these patients is probably bone marrow transplants, because that is the only way you can, allogenic bone marrow transplants, if they had a sibling, and that is the only answer, a final cure. Otherwise you just land up giving IV gamma globulin for a long time, and many of them don't survive we've had deaths. At SGPGI we had 2 brothers who died, I remember, and then they don't survive for very long unless they go in for allogenic BMT.
In this case, if the immunoglobulin levels were normal or slightly reduced, can we think of any other cause for this? Congenital.